In this lecture, we will explore the clinical features of acute cardiac failure. In the previous lecture, we talked about the pathophysiology. And in the subsequent lecture, we will discuss treatment options. So just to remind us that heart failure is an imbalance between cardiac output and venous return, in which cardiac output is unable to keep pace with venous return. So the preload and afterload are not balanced, and this may be due to problems with cardiac contractility. When we're thinking about clinical presentations, we have to think about whether this is the right side of the heart or the left side of the heart. So remember that in left heart failure, the increased preload is building up pressure in the lungs, and the poor afterload means that tissue perfusion will be reduced. With right heart failure, the preload is building up pressure in the systemic venous circulation, so edema in the legs, large liver for example, whereas the afterload, the poor afterload, means that we have poor perfusion of the lung itself. So with left ventricular failure, because of the increased pressure in the lung causing pulmonary edema, patients tend to have dyspnea, PND, and orthopnea. However, because of the poor afterload, they also suffer with fatigue and poor effort tolerance. In right heart failure, the buildup of venous blood causes peripheral edema and jugular venous distension. In biventricular failure, we see a combination of both. So let's look at this in more detail. Acute left ventricular failure, there's an increase in pulmonary capillary pressures and pulmonary edema leading to dyspnea, orthopnea, paroxysmal nocturnal dyspnea, and on auscultation you'll get crackles and sometimes wheeze, but this wheeze is usually not due to bronchoconstriction, it's due to epithelial edema within the bronchi. In acute left ventricular failure, for example after myocardial infarction, there's often no sign of cardiac enlargement. Patients also have increased vascular and sympathetic tone as a result of this poor perfusion because of the poor afterload. So they often present pale, cold and clammy, and they have hypertension and tachycardia. Decreased tissue perfusion may lead to altered mental status, poor urinary output, and poor effort tolerance. This is a picture of a chest X-ray showing severe pulmonary edema in a patient with acute left ventricular failure. What about right ventricular failure? In these patients, for example in a patient with a pulmonary embolus, you see an increase in systemic venous pressure, which may be manifest by elevated JVP, distended liver, or a hepatojugular reflux. In pure right-sided heart failure, again, if we think about the patient with pulmonary embolism, they have dry lungs and often pulmonary oligemia. Eventually, because blood is not flowing through the lung into the left heart, these patients often also have poor left ventricular output, leading to low blood pressure and signs of shock. And finally, biventricular failure, which is usually a chronic problem, and patients may present with acute decompensation. These patients have enlarged hearts because of ventricular dilatation and may have a displaced apex beat. They have chronic fluid and salt retention, leading to edema, ascites on the right side, right venous side, and pulmonary edema on the left venous side. So essentially they have signs of both left and right ventricular failure. And this is just an echocardiogram of a heart showing very poor ventricular contractility, which in both ventricles, which would lead to cardiac failure, biventricular failure. Finally, we just want to talk a little bit about cardiogenic shock. And this is cardiac failure, usually left ventricular failure, in combination with poor peripheral perfusion and hypotension. This is usually due to extremely poor cardiac contractility in a failing heart, often secondary to coronary ischemia. The more common mechanism for this is just severe compromise of left ventricular contractility. But it should be borne in mind that patients who have poor right ventricular output, so for example, a patient with a right ventricular infarct, may not be pushing enough blood through the lung to get to the left ventricle, and that may cause hypotension without signs of pulmonary edema. That was a very brief talk on the different types of heart failure. If you have any questions or comments, you can post them on our WhatsApp group or on the website, and we'll try to get back to you. So in summary, we looked at the signs and symptoms of right heart failure, left heart failure, biventricular failure, and the cardiogenic shock.